Hi, my name is Dr. Panetta. I'm a cardiologist here in the Twin Cities in the state of Minnesota. I want to talk to you today about an electrical rhythm that you may have been told you had called atrial fibrillation or atrial flutter. Before I get into those details, I'm going to first go over a basic diagram of the heart. The heart is basically two pumps that are connected. You have a right pump and a left pump, and each pump has an upper chamber. These two pumps and these two upper chambers are connected by a common wall, kind of like a townhome. Blood comes from your body and your head and goes into this right upper chamber through this one-way valve into the right pump. The right pump then shoots it out to the lungs. The lungs oxygenate the blood and they return via these four veins to this left upper chamber, and this is going to be important in a minute. The blood then returns to this left upper chamber that's oxygenated, goes through this one-way valve to the left pump, and this left pump then pumps it out to the rest of the body. So blood comes into the right pump, pumps it out to the lungs. Lungs return it to the left pump pumps it out to the rest of the body. So the electrical system is basically, you have a power station here. It's called the sinus node, and it sends an electrical signal over the upper chamber of the heart. And in the EKG, that's that first bump called a P wave. The electrical signal then is blocked except for this one little gate, and forces that signal to go down to both the right and the left chambers, and you have what's termed a QRS on the EKG. So the idea is that the signal coming up over the upper chamber tells those upper chambers to contract to push blood into the respective lower pumps. And then these lower pumps get the signal and they pump it out to the lungs and the heart and the rest of the body. These two upper chambers are called atrium and these two lower chambers are called ventricles. So normally you have an SA node or a power station sends a signal over the upper chamber of the heart, you get the P wave, and then it travels through the special wires through the lower chambers of the heart and you get a QRS. Again, signal over the upper chambers are atria, left and right and left atria, and then going down here signaling the both right ventricle and left ventricle of the heart. Atrial fibrillation, on the other hand, is instead of having one signal, you have hundreds of signals firing off where these veins attach to the left upper chamber. They in turn shower the upper chamber with a signal, and you don't get a P wave. And these upper two chambers, or these two atria, just fibrillate or quiver. That causes two problems. One, it can shower the lower chamber with a lot of signals, and so you have an increase in heart rate. And the other problem that is actually more worrisome is in this little sac off to the left chamber called left atrial appendage. This little sac then just quivers instead of contracting, and blood can stagnate, form a clot, and that clot can flip off and cause a stroke. So the mainstay of therapy is, number one, prevent that clot formation. And the risk of that clot formation is going to be based on your age, based on multiple other reasons. And number two, control that heart rate. And controlling that heart rate can be composed of two paths. One path is to just use a medication that blocks or slows down the number of signals that get through. That's called rate control. And then the other path is to try to suppress this rhythm or encapsulate that rhythm up, those extra signals up here. And that's called rhythm control. Now, unfortunately in medicine, this therapy is not 100%. In fact, at best, it's 70 to 80% successful. So consequently, we always have to worry about stroke prevention. That's always in the back of our minds. But oftentimes it's worthwhile to try rhythm control in a variety of situations. Some people, if they feel better, some people it helps their heart function better as well. Some people have problems where when they're in atrial fibrillation, they go too fast, and when they're in a regular rhythm, they go too slow because they're on medicines to keep their heart from going too fast when they're in atrial fibrillation. So those scenarios, we can fix the rhythm permanently, and we'll go into that in just a moment. That's oftentimes better. The other alternative is to put in a pacemaker, and that pacemaker will in turn keep your heart rate from going too slow. We'll go into that in just a moment. One of the challenges with atrial fibrillation is to prevent stroke. Again, this left atrial appendage will just quiver because it gets lots of signals instead of contracting in an organized fashion. So blood can stagnate here and form a clot, flip off. Now, there is a risk score for those who are at higher risk for forming clots up there. And today we use what's termed the CHADS-VASc score in 2024. And you get points for certain criteria, such as if you've had a stroke, you get 2 points. If you're age greater than 75, you get 2 points. The rest are 1 point, 65 to 75, diabetes, hypertension, atherosclerosis, which is that plaque or blockages that can develop inside the vessels of our body. And the controversial areas, if you're a woman, you get a point, and they're thinking of retracting that. That's being debated now. So they add these up, and if you're 2 or greater, then you should be on an anticoagulant. Not an antiplatelet, but an anticoagulant. And these anticoagulants are the most effective at preventing those clots from forming and reducing your risk for stroke. The classic anticoagulant is warfarin. It's been around for years. The challenge with warfarin is it does have highs and lows. It's an effect. And so people can both clot and bleed, unfortunately. Not everyone, but some people can. It's affected by what you eat, and you have to get a blood test every once in a while. So then came out a newer class of medicines called NOACs, or novel oral anticoagulants. And these novel oral anticoagulants are broken down into antithrombin inhibitors and anti-factor Xa inhibitors. And you have both Pradaxa or dabigatran here in the antithrombin arm, and you have both Eliquis and Xarelto, and these are called rivaroxaban and apixaban. You'll know it by the trade names Eliquis or Xarelto and Pradaxa. And they all work very well. You don't have to measure blood levels. They just have to be adjusted based on your kidney or your liver function. If unfortunately some people cannot tolerate an anticoagulant, falling, bleeding, then they have another option of doing what's called a left atrial appendage occlusion. And there are 3 devices out there. One is called the Watchman device. You go up through the leg, poke a hole here, and deposit a little plug. The same as with the amulet. It's also another plug that fits right there. And then the device, everything else is removed, and what's left is just the plug. And then a device that was around before these devices were on the market called the Lariat, where they actually, again, put a wire here, and it has a magnet, and then puncture into the sac around your heart and put a lasso around it, and then tie off the left atrial appendage. And of course, if you unfortunately need open heart surgery, they can clip it or surgically suture it off. So now we're going to move on to what to do about the electrical rhythm. We've dealt with the issue of stroke prevention, and that's being handled. And now the next phase is what to do about your electrical rhythm. Again, normal rhythm is you have a sinus node or a power station that sends a signal over the upper chamber of the heart and then feeds the lower chamber of the heart, that classic P wave and then a QRS. Atrial fibrillation, you have hundreds of signals firing off over here. They shower the upper chamber with that signal, and that in turn causes a high rate. One thing I did not mention is it's called atrial flutter. It's a sibling to atrial fibrillation. Instead, it's one large circuit that runs about 300 times per minute, and it sends a signal, every other signal down here, so people can come in with a fixed rate of 150. Also risk for stroke. And oftentimes, you fix this, and they convert into atrial fibrillation. So, I mentioned earlier, rate control versus rhythm control. Do we just control the rate here at the AV node at that one junction where the signal gets through? Or do we try to fix the rhythm? Ideally, we'd want to cure this, but unfortunately that's just not possible. We can reduce its likelihood of coming back, sometimes up to 70 to 80%. but it doesn't, unfortunately, cure this disease. Rate control, it's oftentimes the first step when someone presents with atrial fibrillation, especially if we don't know how long they've been in atrial fibrillation. We don't want to convert you to a sinus rhythm if we don't know how long you've had atrial fibrillation, because you may have a clot sitting here. And we don't want you to convert into a sinus rhythm and then have this appendage kick out that clot. So first step, anticoagulate, as I mentioned, and rate control. Usually using a medication such as a beta blocker class like metoprolol or atenolol, bisoprolol, carvedilol. Another class of drugs are calcium channel blockers like diltiazem or verapamil. They help slow the rate going through. An older medication that's still being used today is called digoxin. Now they each have their pluses and minuses, but they do seem to work fairly well at keeping that heart rate down. In a very rare situation, a doctor may have to go up and actually cut this signal so that no signals can get through. That's called AV node ablation. This is very rare. This is needed, but sometimes it's required. And in that scenario, people do require a pacemaker to be placed here because the signal can't get through. And that pacemaker will then have two leads, one up here listening for a signal, and then it will tell the pacemaker to fire off down here so that the lower chambers contract. So this is under rate control. After people have been anticoagulated for 3 to 4 weeks, sometimes 6 weeks, and they know that it's relatively safe to cardiovert, you could bring people in and they can be put to sleep and shocked, and that's where they put pads on their chest, put to sleep for a few minutes, cardiovert you back to a regular rhythm. That electrical cardioversion success rate is very high, 95%, but unfortunately the relapse rate is also high depending on the person. And then you can track and see how they're doing and see how they feel. And if they get converted to a sinus rhythm and they say, hey, I'm feeling really much better in a regular rhythm, and then when the AFib returns, they may choose rhythm control. Rhythm control can require different sorts of medications, such as amiodarone, sotalol, or flecainide. And these drugs work by preventing or inhibiting these signals from arising right where the veins attach to the left atrium. And they can be upwards of 70% effective. Unfortunately, though, there are side effects associated with each of these, and they can be gone over with your physician, depending on which one is picked. You still, again, need to be on an anticoagulant because they're not 100% successful. But in certain cases, people can't tolerate these antiarrhythmic medications, and then they rely on atrial fib ablation, not AV nodal ablation, but AFib ablation. And AFib ablation, they go up through your leg, poke a hole here, and then they encircle these areas with scar tissue. And it's also called pulmonary vein isolation because they isolate those signals up into the pulmonary veins here, these tubes coming from the lungs to the left atrium. And they prevent those signals from entering the left atrium. In the best of hands, 70 to 80% successful. Sometimes people have to come back and have it again. It is not a short procedure. It sometimes takes 3 to 4 hours. But the people who are doing these procedures, the electrophysiologists, have become very successful at it. Conversely, atrial flutter, as I talked about earlier, that also can be ablated, where they can go up through the leg and they can cut this the same way, not with a surgical knife, but using radio frequency waves to block that signal. In both cases, whether rate control or rhythm control, the goal is to make you feel better, and potentially in certain patients, it makes them breathing better as well. Again, it's important to prevent clots so no stroke occurs, and then also control the heart rate so it's not going too fast, and then potentially rhythm control to keep you back into a regular rhythm. I hope this helps your understanding of atrial fibrillation, and working with your primary care provider and your cardiologist will be imperative and helpful as they can walk you through this path, have you taken care of. Thank you.